Yes, so I'm glad to be here again, and I've been really impressed with this intense working group. Looking forward to continuing our discussions where to go from here after this presentation. So obviously I don't want to duplicate what Dr. Yu so eloquently and elegantly did. I just thought, what can we do in order to actually link clinical care and research, and how can we improve our recruitment and our retention? So what is needed with maybe limited resources to get high quality data? So I briefly want to review what are research study goals, what are the challenges, and then what are the best clinical and research as well as care practices. What should we focus on in order to enhance both the clinical care and the data integrity? And I think maybe during the discussion we can also think a little bit how to integrate clinical care and research. So I understand that as a clinician you have the wish to learn a lot about the family, and we've heard that you also believe that it's therapeutic and helps parents to spend a lot of time with them. But if that's the case, then why isn't every child hitting your services being interviewed for an hour and a half with the KSATs by the clinician? They should ask these questions anyway, but if you do this year after year, soon you'll have 1,000, 2,000 kids that are clinically diagnosed with a research interview, and then when they come back or when you follow up, you might do this in a year or two again. So you're standardizing clinical care. Your trainees learn how to really ask every question, and at the same time you're building a very large database, and then after a while you might even add genetics to it, or a subgroup that you have in your database. You do certain biological tests because you want to focus on X, Y, or Z. Now I understand that for autism it's a little difficult and different because the KSATs is not sufficient, but that's a small group. And for those, the parents are eager to spend another 3 hours to do the ADOS or the ADIR. So I would just pose to all of us that we should go the extra step and standardize the hours that we spend with the parents anyway, the questions we ask anyway, and actually standardizing it. Because the research study goals are not that different from a clinical goal. They are just more standardized. That we want to answer a few questions, and when you see a family and a patient, one question you want to answer is, what's the diagnosis? What's the problem? And how can I help? That's not very different from a research question. Obviously, in research, we want very high validity, very defined procedures, and high reliability, but then this internal validity that comes from it might lack external validity because we're usually restricting it to a very small group. But if you apply these procedures to all kids you see, that would be really very helpful. Now, I understand that during follow-up visits, you have to do this in a very short period of time. But intakes at university hospitals usually have much more time attached to them. So the trick would be to start with an open-ended interview to really learn about the family and make them feel comfortable, and then to switch gears and say, now we want to really understand what's going on and do the research interview. The problem is that the question then becomes, do you do this separately with the kid and the parent, which would be an hour and a half each, or do you do it integrated? And all of this would need to be figured out. But I think it would be important for us who we work at institutions that are academic to try to combine research and clinical care as much as possible. You've already seen this slide, and I totally agree. We need to not only focus here, but we also need to incorporate the assessments as pragmatic and easy as possible of these other components. And I'm glad to hear that you already do a GAF as well as a CGI on all your patients. I think a CGI is critical to just know where the patient is, and then to maybe have clinical case conferences on those that don't respond. But it anchors the team in talking about the same thing. So the value of measurement has already been discussed. It contributes to the diagnostic process. It establishes baseline severity, so we want also some measure of severity that we can then ask again, and even if it's just a 10-point visual analog scale, how depressed are you today, out of 10 being the worst, so that we have something that might be very quick, even in a 15-20 minute encounter. This is possible. We want targets and treatment goals. Obviously for that you need a more detailed assessment, so not just depression, but is it also, do you feel suicidal? Can you not leave the house? Is it sleep problems or appetite problems? So identifying the targets. And I think we in psychiatry should use the same approach like in medicine, that we identify the treatment goals and attach the treatment for each of those goals, rather than being a little mushy. Yes, it's depression and we give 3 or 4 medications. So having a much more targeted problem list and saying what the plan is for each of the problems would behoove us and would be good. Because that can then help us to evaluate the efficacy of treatments, both psychosocial and biological, and also to evaluate obviously the tolerability, which then both together will help us to see what the level of care should be. Clearly, measurement is good for documentation. Especially in the US now, there's a lot of reimbursement attached to the quality of care, and there are indicators of care. If you're doing the right thing, you get reimbursed, otherwise you don't. Litigation problems, so I mean, maybe this is not as important here, but documentation is obviously critical. So what are the challenges? Well, we have general mental health challenges that I touched upon yesterday too, that these disorders are very disabling. The earlier they start, the more disabling they are. But we don't know the pathophysiology, we don't know predictors, and youth are a moving target. So we need to try to capture this development in parallel with the disorders. There are physical comorbidities we need to focus on, not just psychiatric. Also in the, obviously, diagnostic process, as we've heard this morning, that you need to rule out some biological parameters that influence the disease. We need to look a lot at psychiatric comorbidities. It's not just one disorder. In kids, they have usually a lot of disorders. And we need to remain open. What you identify now as a diagnosis or co-disorder in a year may be different, and we need to really stay attuned to changes, new onset of disorders or morphing of a disorder into another one. And we need to assess the functioning. And as I said, if you build like a whole database of many patients diagnosed in a rigorous way, you can also then look at some predictors of outcome, which may be very helpful. But what are the obstacles to measurement? And we've already touched upon a number of them. Well, many clinicians might not appreciate the benefit. They might say, I know what I'm doing. I have clinical experience. There may be a judgment that I only need one item, better or not better, or it's enough to have this global assessment. We've heard this morning already there can be biases, and there is an expectation bias, which means that the doctor always feels they are right anyway because they don't measure anything to disprove them, which perpetuates the system. But I think that one of the biggest ones is the time constraints, and we need to adapt our tools to the purpose and the setting and the time that's provided. And I think that's something we as a group might also want to work on. There's a lack of appropriate instruments. We just talked about it, that for certain purposes, the screening for multiple disorders in non-psychiatric settings or in clinical psychiatric settings, we don't have appropriate tools. And then the question is, once you have a tool, are the people using the tools adequately trained? Are they supervised? Is there a method of avoiding rater bias and drift? So we, for example, that's for a research study again, have very regular diagnostic consensus conferences. People bring in their ratings and have to say why and justify, and then we come up with consensus diagnostic decisions. And not only do we want this consensus, but during the consensus building, the team is constantly anchored and re-anchored. Why did you ask this? Or why did you use this information to come up with this rating? And it's always the case, because time is short, if we miss an item, then they can in real time go back a week later and call the parent again. We have one more question to clarify things. And I think this rigor helps both clinical care and research. And then there's obviously confounding in the measurement that just because we know patients or we see them multiple times, we just believe they are doing better. And for randomized controlled trials, obviously that can be a big problem. And then there needs to be quality control, as I just said. So these consensus conferences can be helpful. It's also really important when you do a study, as you know, not to only at the end look at the data. You have to do it constantly to see where the problems are. Are there systematic omissions or systematic errors? Is there internal consistency? If you have different scales measuring a similar dimension, are they at odds with each other or are they going in the same direction? So you may want to do some spot checking. There can be external validation. So if the clinician says the patient is mildly depressed, but if you have the Beck depression inventory, the self-rating, and they are markedly depressed, well, then you have a problem and you need to assess what's going on. As I said, over time there can be rater drift. Don't just believe because you've trained people once that they know and do the same thing. And so there needs to often be retraining. And there can also be changeover of staff. So it's good that you have a core group of very experienced people who can then always retrain newcomers. What we do is that, first of all, they just shadow, they observe, then they look at some videotapes, they become reliable, and then they do it in front of experienced people, and then they do it by themselves. But again, they also bring in the ratings, and we discuss how they came up with their determination of the scores. So reliability is crucial, since we do not have unlimited resources and time, and particularly ex-US research and clinical care, as Dr. Yu and I just discussed, are such a double burden, and then you also have to do teaching, and you have a life, so how can you put everything together? So I think for everybody it is helpful to try to have as good a measurement as possible, to need smaller samples to show a significant difference. So here you see basically the reliability of scores. The higher the reliability, the smaller the required group is. Yeah? So it's very important that we have good, reliable assessments. So what are best practices then, after having talked about some of the theoretical issues? Well, I think what breaks most studies is the recruitment rate is too slow, or that we get inappropriate patients. So you may have found certain ways of it. I just listed a couple of things that have been helpful for some of the studies that we are doing. And there is this adage that once you want to study a disorder, it's going to be cured around you. These patients just disappear, that you think they were so eligible and should be everywhere. It's so hard to get them. So you need to obviously establish and groom your relationship with local providers. They should see a value in spending the extra time of thinking about you, making the phone call. What are you giving them back? Are they getting maybe side effect data? Do you take some burden of assessment away from them? Do you train them afterwards and give them feedback? Is there something of value that they see? So we do a long time now, our satiety study, where our initial data were published even in JAMA, which basically is a safety monitoring study. So how did I get the clinicians to at least collaborate? Was because it's easy for them. They prescribe an antipsychotic where parents say, oh my God, I don't know, I don't want it. And they say, but we have experts here. If it's okay, they come, they measure everything in terms of side effects, and they give you and me the information we need. So basically that moves a little bit the burden of the discussion of the side effects and the yes or no to the research team, and they get all the assessments they need for good documentation. You want to create a team spirit, so give out mouse pads with your study name on it. Give them something back that they're on some minor papers, the main recruiter or referring sources. So having something where people feel we are part of it, we're informing child psychiatry. This is a question where nobody knows what to do, and we as an institution really move the field forward. Attending team meetings can obviously be very helpful. Always respond, and always respond quickly. If a clinician calls and makes a referral and hears nothing, this is the last referral for life. Yeah, so it's really important that we have a quick turnaround and response time. I always give my cell phone. All of my providers and even family members that are in studies have my cell phone. They can always reach me. And with that availability, they don't abuse that. At least they feel there's somebody who's really committed. Mail providers has not been helpful to us, so mailing to pediatricians or anything, it's too impersonal. I haven't found this to be really helpful. Internet sites, sometimes self-help groups can be helpful, but the more impersonal it becomes, the harder it is. But once you have a patient in there, that's only the first part, correct? We also need retention, both in clinical care, you want people to come back, but particularly in research. Many questions can only be answered longitudinally. I mean, cross-sectional is okay, but really to make a dent and to find out something, you need prospective studies. So one of the biggest threats is that you have dropouts that are not at random. They actually are related to your outcome. More severe patients drop out more, or those that respond better and don't need further care. Those that have more comorbidities and complications. So it's very important that you try to follow up. Andy Leon, who unfortunately passed away 2 years ago, who is a statistician who we worked very closely with, he felt from a statistical standpoint that he had such a hard time analyzing data and created a very simple question that he asks everybody to ask families. How likely is it that you will come back for your next appointment? And if patients say it's not very likely, or I don't know, then that would get a flag, and he would use that to co-vary for the assessments. But I would take this as a clinical tool. If somebody says, nah, I'm not so sure, why? Yeah, transportation. Okay, here, we'll get you a cab. Try to address the barrier that they're loosely formulating before they drop out. So I think that's a very crucial point to, like with non-adherence, to anticipate this and to address it before it occurs. In clinical care, we do it. We should do it in research too. Reminder calls the night or the evening, the day before, increase the retention and the show-up rate quite a bit. And we do a lot of home visits. Families cannot miss any more work, or kids cannot miss any more school. We drive to people's homes 6 a.m. in the morning to get fasting blood work before they go to school. So consider in-home assessments, consider even in-home interviews via Skype. We are starting to do this now, so to make it as little time consuming for families as possible. And then assessments. We already heard about scales, but it's very important to clearly communicate, set the expectations, how long will it take, try to have a reliable team, always use informants. In child psychiatry, what we do, if there's only one scale, we always split it and make a new scale for the parent and a scale for the kid. Unless in very mentally retarded or young or autistic kids, you can't even assess the kid. Allow sufficient time. Avoid baseline inflation. So if you say patients can only make it into a study if they have scale score X or Y or Z, clinicians might actually inflate the score. So it's important to try to avoid that. And then blood draws that are important for many biological markers. Many kids are afraid of them. So there are various ways of actually increasing the yield Let patient bring favorite toy or object. Distract or refocus them. Sometimes just visually blocking them from the site of injection can be very helpful. Plan with personalized rewards. What do they care about? Which toy or which sweet will they get afterwards? Use pain reliefs like the cream, the ointment. And as needed, have a caregiver and actually hold them tightly to make this quick. Clear reporting is needed. Have a sheet within an exclusion criteria, fill those out. Be careful to have serious adverse events that have to be reported to either agencies or an internal team that can be followed up, that people are sent to the emergency room or other things. When patients don't consent, when patients drop out, try to get the reason at least. Yeah? Try to learn from everybody, even those that don't come in, even those that drop out. And be careful to report or to record protocol deviation and adherence. I think adherence to the protocol, to the treatment needs, and that's the same in clinical care, yeah? Are people taking their medication? And just clinically, don't ask, have you taken all your medications? Because people will say yes. Yeah, it's an easy way of, I don't want to be seen as somebody who did something wrong, or just get me off my back. I always ask the other way around. How many doses have you missed in the last month, or since I last saw you? This assumes it's okay, we all lose some doses, and now they have to actively go against this and say, no, I took all of them, rather than saying yes, yes, yes. So I think it's important also how we phrase questions in order to get better data. So how can we translate these concepts into tools? So we worked on one toolbox for aggressive disorders. This is available freely online. The TMA toolbox, the treatment of maladaptive aggression in youth. We published this in June in Pediatrics in 2 papers, and trying to come up with like tools that clinicians can print out and easily use in order to streamline the assessment and treatment processes. So we came up with, for example, some acronyms like PRESTO. What's the problem? Who refers? Who wants a change? What's the environment, the context of the symptom, the severity, the clear target symptoms, and the outcomes and goals? So that clinicians have in their mind this grid, these 5 things need to, or 6 actually, need to be assessed at every time. So even for your clinical services, having this in an organized way that everybody writes something for the P, the R, the E, the S, T, E, the O is fine, is helpful. But then also for research purposes, you have more structured chart information that you can use for a chart review or for screening patients that are potentially eligible for your studies. So I think anything standardized that helps clinicians and informs research is what we want to create. Another one is the description of the target symptoms. We call this BOLDER. So the behavior, onset, location, duration, what are the exacerbating or attenuating factors. So again, if clinicians get into the habit of writing down a couple of words or sentences for each of them, this will be enormously helpful to structure their clinical thinking, to anchor what targets do they have for treatment, to look at the improvement, and then for you doing research, you can harvest these data much more easily. So I think a tailored toolbox would include diagnosis. And as I said just before, whether you ask your trainees to always do a KSATs, or whether you ask families to sit at a computer and fill out questionnaires or diagnostic interviews, but try to have something that is not just a clinical interview. Targeting parts of the disorder could be possible. So if you don't have enough time for the clinician to do everything, well, if the chart diagnosis or the clinical diagnosis is psychosis, then you might want to do psychosis and the mood disorder schedule only. If it's ADHD, you do ADHD and aggressive spectrum disorders, and anxiety disorders. If you don't have the time for everything, be guided at least by the clinical diagnosis. And obviously it's best to also look at all comorbidities. For efficacy, we talked about the CGI and the CGAS or GAF are important. But maybe you could even have a targeted scale. If the diagnosis is ADHD, add a Conners. If it is psychosis, add a BPRS or a PANS. So that you don't do everything in everybody, but build a database that's clinically useful for clinicians also. If everybody who has OCD gets a Y-box, well, then you can really look how the treatment helps. That we're not just too vague. And the more we have self-rating scales, the better implementable it is in clinical care. Also, we need to assess suicidality in each and every visit. We need to assess side effects in each and every visit. And we need to standardize guidelines for health assessments, particularly in patients with antipsychotics, as you mentioned. And then there need to be effectiveness measures. When somebody stops the medication, why did they stop? Clinicians should write this down. What's the reason for the all-cause discontinuation? And if there are predictors that could be standardized, that you have like a semi-standardized intake form where you always want psychiatric history, where you want maybe birth history or something that's relevant to your research interest. And if everybody fills that out, even with chart review studies, you can have quite a bit of impact in a field where we have much too few data. And then if you get a study, you have a database where you can call back people and say, okay, we know that you have this diagnosis, and boom, you can start going with it. So in conclusion then, I think clinical studies and clinical care are separate and different in many ways, but they can also be merged in many ways. And we, being at key positions in our institutions, should really try doing this. Also, clinical care and research are imperfect, and we have to find the best compromise that's really pragmatic and doable. Various components need to be controlled, monitored, and improved, especially also in clinical care. And the more research and measurement you insert into this, the more I think we can improve both clinical care and research. We need patient selection, for some studies blinding, which increases the complexity of the studies. And we need to also know who is the best in actually doing certain roles. If there's somebody who's not very organized or is very much against measurement, you don't want to have them in a key position for a study. So I think the improvement and the characterization of symptoms in our patients is a shared problem between clinicians and research and administrators, and we should all try to share the solutions for that. And clearly this needs experience, this needs networking, and cannot be done without collaboration. So I hope that this will be the beginning of lots of collaborations. Thank you very much.